Good evening, everyone, and welcome to tonight's education session, Ethical and Legal Considerations in General Practice. So this is our final series out of the two. My name is Basala, and I'm one of the education coordinators at the South Australian Postgraduate Medical Education Association. And I'd like to acknowledge the Aboriginal and Torres Strait Islanders people. As the traditional custodians of this land, we pay tribute to their physical and spiritual connection to the land, waters, community, enduring now as it has been throughout time. We pay respect to the elders past, present, and emerging. A few housekeeping rules before we begin. Microphones are on mute, please. And if there are any questions throughout the session, please submit this through the Q&A feature. Please let us know if there are technical issues. Just send through a chat. And at the end of the session, there is an evaluation form. Could you please fill this out as well? This really helps us with our education events in the future. And statements of attendance will be sent out after the education session. And then I'd like to hand over to Dr. Shirley Fung, who is the Chief Medical Officer and Director of Education for Partnered Health Medical Centre.
Thank you, Basala, and welcome everyone to tonight's webinar, part 2 of our Ethical and Legal Issues in General Practice series. Tonight we'll be covering managing investigation results as well as complex case, how to gain informed consent. So Partnered Health operates 60 clinics across Australia, and we love sharing knowledge across our network between clinicians that are internal to our network, but also external experts like Paul tonight. So we're honoured to have Paul Saucius, who is the Head of Practice from Advance New South Wales, and he's had extensive experience in health law since 1991. He's been advising and representing both hospitals and doctors on many hundreds of matters, including medical negligence claims, coronial inquests, hearings, and professional conduct or disciplinary proceedings as well. And he does absolutely understand the stresses and strains that doctors face in their daily practice and profession, and their need for medical legal support to help them do what they do best. So I'd like now to hand over to Paul for his presentation. Over to you.
Thank you, Shirley, and thank you for inviting me to give this presentation. I hope everybody can see my screen. Is that the presentation screen? Is that correct? Is that okay?
Not yet. Not yet. We can't see that yet.
Okay, let me just share. Is that okay now? Can people see that?
We are on the presentation presenter view.
Paul, just go up on the display setting on the top.
Yep.
Click on the display setting with the arrows.
Yep.
Is your mouse there? And
yep.
Yeah. So click on display setting, and then there'll be an option for you to swap the screens.
Well, it says it's actually sharing now. It says you are sharing your screen, so people can't see my screen.
Oh yeah, we can see your screen, but it's just on the presenter mode. So we just want that full screen for everybody to see. So we'll go to display settings.
Okay. Yep.
Yeah, and click on that.
Yep.
Yeah, and then swap presenters view. The first one. Yes,
okay.
There you go.
Is that okay? Okay. Thank you for that. Thank you. Thank you very much. So obviously, doing all that probably shows my age, because I'm not very techy, but I always have people helping me. So thank you very much, Basala. I really appreciate it. Okay, so let's start. Follow up. Now, just this first slide, it talks about the duty to the patient. It talks about extending to examination, diagnosis, and treatment of the patient and the provision of information, and that includes follow-up. I guess the best way of putting it is that your duty of care to a patient extends to every way that you can treat a patient, okay, and involved in their management. And that's borne out by a famous case, you've probably heard of it. It's called Rogers and Whittaker. The High Court said that many years ago. I think it was 1981. So it extends in a holistic manner to everything, to all your touch points with patients. Now, generally speaking, patients can decline, follow-up, but again, it comes down to having proper advice and understanding, and ensuring it's documented, and having a good systems in place to ensure any test result, specialist letter is reviewed and acted upon, and also ensuring that the pathology and service provider you use are trusted and you can rely upon them. There have been legal cases involved, inappropriate referrals. These are just general principles for the moment, and we're going to drill down into them more shortly. I can't say enough that how important an efficient system is to track patient results and their diagnostic results and important referrals, and not waiting for patients to act. They won't always know or understand as well as you do. And obviously you can have a great discussion, but I've seen cases where the discussion's been had and the doctor will tell me the discussion's been had, but obviously it hasn't sunk in, or the patient hasn't understood, and it's resulted in a legal case later on. And obviously document all your attempts when speaking to patients about investigation results, referrals, investigation results. I just want to talk about one case now, just which highlights the importance of following up patients and ensuring they attend referrals. It could be test results. I will talk about test results in the next case study. But this was a man, Mr. Input, and he passed away. He was only 28, and he did have chest pains, but I think they were non-specific. But he went to a clinic. He was seen by a doctor. This is in March 2020, and the doctor ordered a fasting cholesterol test and to see a specialist at the practice. Now that was on 2 March, and they had a specialist clinic at the practice, which was on 21 March. Now that was cancelled. No, I can't give you the reason why it was cancelled, but it was cancelled, so he didn't go to it. But in any event, there's a good chance if he did go, there would have been a kerfuffle, because they sent to that particular clinic the wrong patient's file, or somebody else's file with the same name. It was a relative. So he didn't go to that clinic. The clinic was large, it was paper-based, and so he was seen multiple times by doctors after this, down to the end of the year, and nobody picked up this cardiac issue. That had to be chased down, and he basically had a cardiac arrest and died at 28. So what happened then was and I'll talk about what the court observed, but his family commenced legal proceedings against the practice, and succeeded in that case. And I think in that case, it was easier to go for the practice because it was responsible for the system at that time. And the main doctor who referred the patient, his referral was deemed appropriate. I don't think he saw the patient again, so it was only a one-off. And the other doctors who saw the patient didn't see the results, these examination and plan earlier on. So he passed away, and the court observed that the first defendant, that which would have been the practice, had a responsibility to put administrative procedures in place for the situation that arose in this case, where a patient fails to attend for a fasting cholesterol test, which is part of the treatment plan for a potential serious condition. So it's a good example that the system in this case was poor and didn't succeed in ensuring the patient had appropriate follow-up. So what went wrong? They had an unreliable system to pick up non-attendance and flag non-attendance to the next practitioner. The entries made by the first practitioner weren't read by subsequent practitioners. There's nothing in the patient's file to indicate that there were two patients of the same name, and Mr. Impu himself was at fault because he failed to tell anybody that he hadn't gone to this for the cholesterol test, failed to agitate seeing the specialist himself when the clinic fell through, and on that score, the court said that he was 50% liable for the outcome. So damages were reduced by 50%. So that case was one which was principally, the liability was found against the practice rather than the doctor who was involved. But generally speaking, doctors, the person who initiates the test, has a burden as a requirement to chase down the result or ensure the results are acted upon, or hand over the case to another doctor or somebody to ensure if they're leaving, if they're going on extended leave, that significant referrals and investigation results just aren't left in abeyance. So this slide here just confirms that doctors have a clear duty to follow up and track significant referrals and test results. So it's not everything, and the law does mean that you have to make a decision. I guess clinically, you can't chase everything down. So, but if it's clinically significant, it has to be chased down, whether it's a referral or an investigation result. And it said traditionally courts have expected very little from patients in taking responsibility to follow up their own care. That wasn't the case in Mr. Impu's case. He said that he did have a responsibility, and I think today things are changing. I think the courts are far more willing to apportion responsibility between a legal practitioner and a patient in terms of failing to act on a referral or for follow-up. And as you'll see, delegating to your patient or trusting your patient will do the right thing won't succeed in a liability action, and that's why tracking systems are very important. Considerations, and again, this goes to the issue of what's clinically significant. Is the medical condition serious? The risk of the patient either delaying or not receiving the medical treatment, whether test results are abnormal, whether the patient is dissatisfied with their treatment. It comes down to a matter of clinical judgment, but if it's clinically significant, you have to act upon it. And we have had cases where we've given advice where it's very serious. The patient could pass away imminently or have some form of episode, neurological episode or cardiac episode imminently. And I've had, my colleagues have had to give advice to try and track that patient down as soon as possible and bring that to their attention. And that may mean you bypass the usual telephone call, sending it doesn't work, but it works fantastic first go. Sending a letter, by registered post and waiting. If it's really serious, then you might have to make a direct approach to the patient, telephone call, or maybe even sending somebody out. We've had to advise a practice or calling the police and asking them to try and locate somebody because it was so dire. So this is just a recap. You have a duty to follow up abnormal test results, and again, the issue of referral, what's reasonable, what's clinically significant. I'd say these days, following for referrals just as significant as an investigation, informing a patient of of a significant investigation result. And importantly, when you do provide a patient with information to make an informed decision, either to have an investigation, to accept a referral and to follow up on the referral, document that in your medical records. If it's not documented and you have a complaint or a court case a year or two later or 3 years later, it's very difficult, proving your version of events. Some say if it's not written, then you have no defence. I wouldn't go that far, but it makes it very difficult. Now, this second case study involved a 21-year-old woman who presented with a breast lump. She had a biopsy, a fine needle aspiration was taken, but not recorded in the notes. And the patient was told to phone for the results and return for follow-up in 1 month. But she did neither. The surgeon never saw the report, and the patient returned 12 months later, and she was diagnosed with metastatic breast cancer. Now, the results should have been acted upon because the results were that the indicated that the specimen was highly suspicious of underlying carcinoma. So 12 months was lost, and the patient in that case succeeded against the doctor. The judge said, irrespective of whether she rang up about it, she was entitled to assume that if the outcome of the testing of the biopsy gave cause for concern, she would be informed. So the failure to follow up with the appointment was not in accordance with competent professional practice. Now, just this slide goes on to just talk about an interesting point in law, which is the fact that a breach has happened. It doesn't necessarily mean that a patient will succeed. The second link into a legal action is whether or not the breach caused some form of damage. So, she had to have shown that the diagnosis of metastatic disease could have been averted. Was it had it metastasized by that stage, or could there have been a better outcome if diagnosed 12 months earlier? And a patient in a circumstance like this won't succeed if they can't show that if the evidence is the other way, that it wouldn't have made any difference, that it had metastasized, that the likelihood of a better outcome wasn't on the cards, on the balance of probabilities, sorry. So this slide again reiterates that every practice should have a system for follow-up, and I'm sure your practices do, and recalling patients who have been referred to a specialist and have abnormal results. As I said, the practices normally have the systems and are responsible for the systems, but what doesn't come out in this slide is that a doctor still has their own individual professional responsibility to ensure that results they've ordered in particular are acted upon. That's another recap on the case law. So take reasonable steps to remind the patient to have recommended test or procedures, follow up the test results that any referring practitioner has recommended if you're stepping in for somebody after they've seen the patient. That's quite common in today's practice, and advise the patient of those results. Documentation, as I said, for a lawyer, this is crucial for me in terms of being able to successfully defend a doctor or a practice. Document all patient attempts at contact. Do not assume that the patient requiring treatment has gone elsewhere. Don't leave it up to the patient to be responsible for their own care, and ensure contact details are up to date. Just before I go on and just put some tips up, the last case involved an investigation result, but there's another case which it's an example of a referral, and that involved a doctor who went down, who didn't succeed in a case where he gave a patient a referral and in a country area, and they couldn't go because it was just they wanted somebody closer, and that led to the GP finding that he said that it was okay to that they could wait. And the waiting ultimately led to a delay in the patient's condition, and that doctor went down in that case because of that delay and failure to have a timely referral. So again, that's just an example where that fell onto the doctor and not the practice. That it's a holistic thing. The practice has its part to play, but also doctors are an extremely important part in the cog in terms of determining at the outset what's significant, what has to be chased down. These are just 10 tips when following up results. I'll just go through them quickly because I think time's pressing. Aim to have one follow-up system per practice. I think it's a given. I think having more than one is a recipe for trouble. Mark actions and recalls as performed or delete if not relevant. I would say with that, in terms of deleting if not relevant, that there should be some way of being able to still determine what's been deleted. In New South Wales with medical records, and it's probably like the same in other states, you can delete, but not in a way which obliterates something you can't tell what had been recorded before. Keep systems simple. Don't add recall reasons without discussing with the team. Ensure all staff have an opportunity to attend training. Check results to be followed up, but have not been marked as given or notified. Communicate your system with your staff. Mark results as given or notified. Label recalls well, and document patient contact, which is very important. Salin, Doctor, do you want to leave answers to the end? Is that correct?
Yes, I think so. I think that would be a good idea.
That's fine. Okay, now we'll just jump to consent. Now, consent's it crops up in almost, it's one of the biggest factors that you see pleaded in cases. In medical negligence cases is failure to obtain informed consent for a procedure. And I can't give you a percentage offhand, but my experience is it's extremely high. It's at least 50%, possibly more of the cases we see in civil proceedings will involve an allegation of failing to obtain consent and the patient having a procedure. They didn't really know, what the risk entailed for the procedure, and if they hadn't had the procedure, if they had been informed of those risks, they wouldn't have had the procedure, being the essence of those types of cases. So capacity. Probably this is the cornerstone of the consent process when you start out. Do you have any concerns about the patient's capacity? And I'll talk to it in another slide a little bit more. If yes, have the patient assessed to determine whether or not they can understand what you're telling them about the procedure or the treatment/procedure. Disclosure. Are you aware of the patient's concerns? Have you addressed the concerns and explained the complications, alternatives, risks and benefit to the patient? Now with that, in that case I was mentioning earlier on, Roger and Whittaker, it's given us a two-tier way of looking at the consent process and risks. Roger and Whittaker requires you to tell a patient what a reasonable person in the position of the patient would want to know. So generally, what would people want to know about a particular procedure? And then it requires you to if it's the case, to tell the patient what they need to know because of their particular situation. And you'll know that because of their, often because of their health circumstances or the questions they're asking you. In the Rogers and Whittaker, the situation was, I'm not sure if everybody's aware of this case, but involved a 1 in 15,000 chance of going blind in the patient's good eye if the bad eye that she had was operated upon. Now, she didn't know that risk, and the High Court said, affirmed that that was a material risk in her circumstance, in her particular situation. She needed to know that because she only had one good eye. So if something went wrong with it, her vision would be, or she'd become blind. So there's a two-tier manner of looking at consent. So just to recap, what a reasonable person in the position of the patient would want to know, and what the particular patient wants to know or needs to know. Scope of consent. Isn't clear what the patient is actually consenting to. Is the scope broad enough to include any unforeseen circumstances? And so that would include, if it's in particular surgical, when you're talking about surgery, warnings and consent that you might have to operate or to extend the operation or do certain things during the operation which weren't anticipated. You've probably all seen that in your medical practice. Voluntariness. Is the patient making the decision voluntarily? Are they under any undue influence? And obviously, in terms of capacity, going back to that, if there is a capacity issue, then and the patient doesn't have capacity either because of age or because of cognition issues, if they're an adult, then that will fall to somebody who will decide on their behalf. If it's a child, it'll be their parents. If it's an adult, it will be there could be their carer, their guardian, an appointed guardian. So they'll stand in for them and make those decisions. So this graph just shows us how we've moved over the years in terms of informed consent. In the early days, there was a lot of paternalism, and doctor knows best, and you would listen. And but since the modern era, and particularly since Rogers and Whittaker, in particular, informed consent is an obligation on doctors to be able to properly convey to a patient information that they need to know to be able to make a decision. Now we're moving in more recent times into shared decision making. Still means patient has to have enough information given to them, appropriate information given them to make an informed decision. But this slide talks about we're moving down to this level where there's a shared decision-making discussion between patient and clinician about what would be an appropriate procedure or treatment for them. Legally, this is the most important one, the middle one here, informed consent, and you can't have this one here without having the middle one, really. So disclosure information. I've already discussed the broad principles of, what Rogers and Whittaker says you have to cover. And this slide's a little bit more pointed. It talks in terms of patient expectation, ascertaining patient expectation, goals and concerns in the process of advising them about possible treatment and management, discussing treatment options, potential benefits of the procedure, alternatives, significant material risks. And this second last one, significant material risk, is what often comes up in medical negligence claims, because normally what will happen is the significant or material risk will come home and cause some injury to the patient or some outcome they weren't expecting, or if it was possible, they're hoping it wouldn't come home. comes home, and then there's an issue about whether the informed consent process was sufficient for them to understand the risk of the procedure or the treatment. And explanation of the procedure, and thereafter, that encompasses, it's just good patient care in terms of telling them, explaining the procedure, and also explaining what's going to happen to them after in terms of recovery. So again, it's a holistic approach. Just turning back to capacity. Central to all capacity is understand the information and consequences relevant to the decision, retaining the information enough to be able to, for long enough to make a decision about the care to propose to be given, and being able to weigh up the information given to you, the pros and cons of the treatment information communicated, and an ability to communicate their decision, and also indicate an understanding of what they're consenting to is important. And again, this is all very can be very organic in terms of discussion with the patient, and knowing that they know will come across with your discussions with them, asking them if they have any questions, querying them and questioning them about their understanding about the proposed treatment and management. Now, this slide is probably very germane for a hospital environment. My advice for doctors in private practice is, if you're going to provide the treatment or undertake a procedure, then it should really be you who is obtaining consent of the patient. I wouldn't be delegating consent if you're the one who's going to be treating the patient in private practice. We commonly see delegation of consent in the public health system, and that's because of the numbers of patients they see and their structure, where they have JMOs, RMOs, registrars, other staff specialists, VMOs, and a VMO may well not be around because they're so busy. We called in to do the procedure, but the procedure itself, but the consent for the procedure will be undertaken by a registrar, by their team. So what are you delegating? Getting the patient's signature on the form, having the consent discussion. Are you delegating that? Fine. Appropriateness depends on the circumstances. Again, if it's private and not in the public hospital system, I would counsel against delegating consent. But even the public hospital system, or in the public system, some procedures can't be delegated. They're so they might be novel or complex that it'll have to be the VMO who will be obtaining the patient's consent. And this last part of the slide just confirms what I'm saying in terms of, if you have to delegate it, you need to know that the person you're delegating to knows the procedure well enough that they can provide sufficient information to the patient so they can make a decision. And what I just said a second ago, that sometimes it could be novel, it could be very complex, and the only way you're going to be sure that the patient understands is if you do the consent process. But again, I think this is something for the public hospital system. I think it's worth mentioning. But in private practice, I think if you're the caregiver, then you should get the consent from the patient. And bear in mind too that if you delegate consent in the public hospital system, that it's still odds on that you'll be, you could be named in the statement of claim as failing to provide that consent. And given that you're the proceduralist, you could still be open to a liability finding for if there's a lapse on somebody else's part in not obtaining the consent. So a lot of risk, but our system does require, in the public health sector, some delegation. So documenting consent. Actually, before I go on, one thing I want to stress in all this, and hopefully it's coming out, is that the informed consent process isn't about a form, and I haven't talked about forms. It's really important that good forms are used and document discussions and the patient's consent to a particular risk. And the more specific the form is in terms of setting out the risks, what they are, the better. But no form in the world is going to save you if you haven't had a good discussion, because patients will sign that form. It'll go onto it could go into your file, more likely into a hospital file, and if you haven't had the good discussion, then they're not going to understand what's happened to them. So it's often said, and we often say at Avant, it's not a form, it's a process. It's a process you have to follow, a communicative process you have to follow with the patient. If you see it as a form, a formulaic, just a form, then it's a recipe for disaster. So documenting consent, make contemporaneous notes of the consent discussion, include patient concerns and worries, include the risk discussed, especially material risks, document specific considerations or questions, which alludes to, in particular, risks specific to the patient, include any written material. Often if there are pamphlets, information pamphlets, make a document that you've given it to them. A lot of colleges will have information sheets for their fellows, and they'll have a tear off or stick on a tear off piece that you can tear off and stick onto your medical records, which you sign, dating and indicating the date you gave the pamphlet to the patient. And the hospital may require a certain form to be used, and it's appropriate. Obviously, you have to fill it in appropriately and lodge it with the hospital, and if you can, keep a copy. And the hospitals often have their own or may have their own process in terms of ensuring that a patient has been consented. So how can you improve the consent process? Communicate preoperatively and before treatment, provide information. Again, shared decision-making. We're moving towards that, and it's great. Patients will feel a lot better if they've had a discussion and they feel involved in the process of making a decision as to the care they're going to receive. Patient expectations, test patient understanding. That's what I alluded to earlier. I mentioned that. Documentation, document discussions. Ensure consent forms are signed. Provide information sheets to the patient and document that you're given those information sheets. And communication post-operative or post-treatment. Provide information on how it went, and if there's any complication or any issue, then have an appropriate open disclosure discussion. That can often be very positive, and it's the right thing to do as a doctor to have any post-operative discussion about, or post-treatment discussion about any adverse event. Good treatment, and hopefully it'll avert complaints or claims, which are often driven, in my experience, because people feel they don't know what's happened to them, or they feel the full facts and circumstances haven't been conveyed to them post-treatment. This case study involves a 73-year-old man, immigrant to Australia, married for 50 years, retired from his position at a telco 9 years prior, so he's 64 years of age, no significant past medical history. He had carpal tunnel syndrome 2 years ago, and due to nerve compression in the neck, and he had conservative treatment. He's fit, active, working daily on renovating his home and his daughter's home, and he's got an active social life. So seems like he's got it all. In February of a particular year, he saw a GP about an issue, having a headache for some weeks, but it wasn't interfering with his normal duties. So CT scan report showed a solid, homogeneously enhancing mass lesion within the midline of the anterior cranial fossa. demonstrating adjacent mass effect and edema within the right frontal lobe, having features most typical of a meningioma. He's referred to Dr. Q, and he consults Dr. Q for about an hour on the 2nd of March, in a particular year, and decision was to proceed to surgery via endoscopy. Just a point of note, he'd actually seen Dr. Q for his carpal tunnel syndrome, so obviously there would have been a past relationship and trust there. And it was that doctor who recommended conservative treatment in that case. So surgery was undertaken 31 March. It took 7 to 8 hours. Post surgery, he had trouble walking. CT identified a hemorrhage. He had 10 subsequent procedures, the final one in August. He was discharged home in December, but he had brain injury and a significant impairment because of that. So the surgery went as expected. There was no allegation in the claim that it was negligently performed. The issue was around the advice given, surgical versus non-surgical treatment. The doctor's training experience was an issue. It never performed the surgery. And so the central issues were the decision to recommend surgery and the consent process. So the information given by Dr. Q, so Mr. M had a meningioma, unlikely to be malignant, but needed significant surgical removal because of the risk of stroke and dementia. He was advised it could be endoscopically removed rather than a craniotomy, and printed documentation was provided explaining craniotomy and the risks of that procedure. The patient's understanding was that the preferable course was to allow Dr. Q to remove the tumour endoscopically and to deal with the, in order to deal with the headaches and to address the risk of stroke and dementia. So what happened in the court case? The experts in that case agreed that the patient didn't have, that Dr. Q didn't have the training experience to perform the surgery. He should have disclosed that this was the first time he would have been undertaking the surgery and carried a 5 to 10% risk of post-operative complications that materialised in that case. And surgery could not have been recommended, surgery should not have been recommended or performed. And the court found that Mr. M was not given a real opportunity to choose between the available treatment options. They were not properly advised of the relative risks, low risk of conservative treatment versus high risk of surgery, and Dr. Q should not have undertaken the surgery. Just before I go on, and just to add my own experience with the issue of doctors only having, no or limited experience before performing surgery, a particular surgery. Often, and I'm not a doctor, I'm a solicitor, so I'm not trying to pretend that I know medicine, I don't. But my experience has been that sometimes in medicine, in particular, obviously surgery, that surgeons will know their anatomy, and that'll also often sometimes be novel surgeries that have to happen, and they will, and so there's not an established procedure or established malady. It'll just be very novel, and obviously that surgeons has to call upon their expertise in order to be able to solve that particular dilemma. And that might be a one-off situation. I think it's good for the patient to know that it is novel and they are calling upon their experience to solve that particular surgical dilemma and to get to the particular area they need to operate upon. But this case will wait to the situation where it was an established procedure, but that surgeon hadn't done it yet on a patient. And so I think it just informs us that in cases where, you haven't got experience in a procedure where others may have, then this case would tell us that you should be telling the patient that it's your first procedure, you haven't done it. I'll obviously tell them why you think you can do it, and obviously if the patient then wants to go somewhere else, have a second opinion, that's a matter for them. In any event, that's how that court case was decided. Now, let's deal with children in terms of consent. In my area of practice, we often find children and consent issues coming up all the time, not necessarily in litigation, but in day-to-day bread and butter medicine, in terms of parents, separating parents, arguing about treatment, you know, and but the patient, the infant patient or the child brought in by one parent, and then another parent will find out later on and said, no, I didn't want that. Why did you do it? So we see a lot of children, issues involving children and consent, and parents having an issue with it in the non-litigation setting, but you know, as a bread and butter area where doctors and practitioners need advice, it's a very common area that we have to advise doctors on. So just let's have a look at it. In general, this is a guardian of a child, usually a parent, has the authority to consent or refuse medical treatment and procedures as long as it's in the best interest of the child, unless the child has the capacity to make decisions themselves. It's called mature minor or Gillick competence, after the case that it's famous for. And also that the procedure is one which court authority is required for. Some procedures on children will require court approval. An example, I know in New South Wales, if it's, sorry, I'm just trying to think. The example I actually isn't a child, it's more if it's for sterilisation of an adult person with incapacity. That's just one example there where you would need approval. Let's march on. So just to reiterate that the person consenting for the child has the legal responsibility to act in the child's best interest. The court may also give consent to treatment of a child where there is conflict about whether proposed treatment is in the child's best interest. And this conflict may be between the parents or parents and a hospital or medical practitioner. Now, I've seen these this one down here typically involved children having treatment involving blood transfusion being very common. I know in New South Wales there's been at least 5 in the last 10 years, parents objecting to treatment, and the court in what's called the Parents Patriae jurisdiction, which every Supreme Court in Australia has invariably ordered treatment to the child. And actually also the Family Court has a power to order treatment for children. So in South Australia, you actually have an act called the Consent to Medical Treatment and Palliative Care Act, and it does state that for children aged 16 years and over, they can make decisions about their own medical treatment, with the exception of making an advance care directive or appointing an agent to consent to treatment. That helps clarify the situation. But what happens beforehand? Does it mean that you're totally locked out? Not necessarily. That Gillick competence case I told you about, the mature minor, could kick in for a child under 16 if they have the maturity to understand, or the age and maturity to understand the medical treatment being proposed. There is no, in our common law system in Australia, there has been no decided case of when that cutoff happens, 12, 13. I think definitely by 14, there have been cases where you could say, yes, it's there, but there is no decided, they haven't decided, that this is a landmark, 14 is a landmark, or 13. We've just had cases where the child has been able to get treatment at 14 or 15, but the principles are all the same. It's about whether they have the maturity to be able to understand the treatment being proposed, the risks, and to make a decision about whether or not they should have that treatment. Just to go back, if a child does have that maturity, then they can make a decision to have treatment on their own. But when we've given advice when when a child's come in to a medical practice on their own, we've always advised to counsel and advise the child, if at all possible, to involve the parents if it's possible. Right, let's go back. So just parental responsibility and the court. Where there's some discordance with parents about the treatment, it's open to normally a practitioner would probably bow out, but definitely with hospitals and a patient needs treatment, they will invariably intervene on behalf of the child and apply to the Supreme Court and seek treatment. In the private practice setting, you will normally see that happen once you report the child. Invariably, you'll find, or you may find, that the parents aren't providing treatment which should be provided. It will give rise to mandatory reporting obligations, report to social services, and they will take that running on behalf of the child and seek appropriate orders for the child, as would a hospital if they're having a child under their care. With separated parents, the obligation of parent interest for the child doesn't change, but both parents do have a right in terms of having a say in the child's care, but both parents don't have to bring a child in for a medical practitioner to gain consent to the treatment of child. You only need one parent, not both, unless there's a court order which changes the normal common law situation. And the same thing goes with medical records. Either parent can access a child's medical records unless there's a court order to the contrary. And when I was talking about also mature minor, the ability of parents to gain access to a child's records will cease when the child becomes a mature minor. When they got competence, they can't access a child's records at that stage. By that stage. And as the slide just reiterates, if parents can't agree, then obviously about treatment and there's a dispute about it, then a court, family court or the Supreme Court may have to be called upon to decide. So where there's a dispute between a parent and a child about medical treatment, provide the child and the opinion of the practitioner is mature enough to consent, the child's consent will be sufficient to undertake the procedure. And that's subject to any overriding court order that the parents may obtain or have in place. I won't dwell on this slide. It just reiterates that there's some legislation in states which requires that you seek court involvement for special treatments involving children. They'll typically be treatments which permanently alter any change to a child's physiology is permanent, will normally need court approval as a general rule. But on that score, if something like that arose, you'd always seek legal advice. That'd be my advice to you, to approach your MDO and seek their input. Well, hospitals, I would seek their legal team's advice. Medical records of the child. what's the age of the child, the younger the child, the less likely they're going to be GILIC competent, and that both parents can access their records. The older the child, and if they have GILIC competence, then the parent shouldn't be able to access their records. If the patient is GILIC, if the child is GILIC competent, then you'd need the patient's consent, the child patient's consent to access their records. And I'm mentioning records because it does come up a lot in terms of medico-legal issue. Consider what information is on the file, because there often could be information about either spouse, and it could be inflammatory, and there could be exemptions available to you under the privacy legislation to redact that information or provide it to the parent seeking access to the health information. And sometimes actually the information the child's given could be exempted under privacy law if it's not in the child's interest that that parent seeking accesses that information. Just a key message in terms of consent overall. It's a process, not a form, but the form's important. Explore what is important to the patient and target your discussion accordingly. Check patient understanding and manage expectations. Document your discussion. Delegate appropriately. Again, I would qualify that by saying that's mainly largely in the public hospital setting. Avoid operating on anyone you have close personal relationship with. Sorry, I should say that would probably be avoid, treating anybody you have a close personal relationship with, or consenting, gaining their consent and treating them. So that's a no-go area. Any questions?
Okay, Paul, I think it looks like we've got one question to start off with, but if any other attendees would like to put their questions in the Q&A section, that would be great. So, so the question is, does GILIC competence need to be assessed by 2 independent doctors?
No, not necessarily. It depends if you feel you have the competency to assess a child. But I would say the more involved the treatment, the higher, the riskier the treatment, the more that at stake with the treatment, then you'd want to be extra cautious and have a second opinion, have a second assessment of the child. So I would say that there's it can be a continue, like some form of continuum. So the riskier and the more involved the treatment, the greater the what's involved in the treatment, then I think the more you'd want to be certain that the child does have a GILIC competence before you embarked upon the treatment.
That's cool.
If it's something simple, if it's something simple, Shirley, then then your own assessment may well be enough.
Yeah, so that makes sense. Thank you. Just waiting for any other questions from our attendees, but I might jump in with a question here while we wait for that.
Sure.
Now, firstly, regarding managing results, what's the obligation for a doctor when they leave a practice for results that they ordered themselves?
Okay. And just to let you know, we do have some fact sheets. I'd be happy to get our risk team to send these on to you so you can pass them on if you like. But basically, it's not a case of just walking out of the practice and saying, I'm done. I would say that your obligation is to bring any significant or patients who have significant needs and have important referrals, significant test results coming in or waiting to be reviewed, that they would have to be handed over in some way to the practice. Somebody responsible in the practice, a medical director, somebody. So you just can't walk out. Otherwise, patients could fall through the cracks. And I think that's a personal, professional obligation doctors would have.
Yep.
It's certainly something we give the exact advice on for doctors leaving the practice, that they should have some form of handover targeting those patients which need follow-up.
Thank you for that. Now I think we're at time actually, and there's no other questions that's come through. So thank you so much, Paul, for your time and sharing
Thank
your
you.
expertise with us.
Thank you. My pleasure. Have a good evening, everybody.
Thank you, and thank you for attending. And this is our last webinar by Partnered Health for the year. So we'll see you in the new year, and have a Merry Christmas and a wonderful new year. And we'll see you soon.
Thank you.
Thank you.
Thank you.
Bye-bye.
See you, everyone.